Hi everyone, I hope you're doing well. This week we're going to discuss vestibular contributions to locomotor control, and we'll do a few case studies. We're going to talk about Meniere's disease. We're going to discuss vertigo and dizziness and its prevalence in an elderly population. And we're also going to discuss children and specifically children with congenital and acquired vestibular loss. And just a shout out to Dr. Leah Bent for the use of some of her lecture slides from HK3100 Neuromuscular Physiology. She uses some of these slides to talk about the vestibular system. Just a few short announcements. First, regarding the presentations, thanks very much for submitting those last week. We're actually working on the marking of those now, the TAs and myself. So we have to, it's taking a little bit longer because we each have to review them, and then we're going to try to compare notes. So we hope to have your grades and some feedback for that to all the groups by next Friday, April 17th. Regarding the group paper, just a reminder that it's due this Thursday by 5 p.m. The formatting is outlined in the rubric, and it is similar to what was used in the journal critiques. So I know I had a couple of questions about margins, those types of really specific questions. So you can follow the same format that we use for journal critiques. That would be great. And the case studies from the laboratories, I have actually posted those now on CourseLink, and they're underneath the laboratory sessions. So those are the ones that I said we, again, reviewed those in the lab content, and I just wanted to make sure that you had a copy of those that you could review. The vestibular sense is actually quite subtle. We've talked about it a little bit in class before, but oftentimes when we're going about our daily life, it's not really a component of our consciousness. We don't really think about it. But when we receive a large vestibular input, such as following a roller coaster ride, something like that, that's when you have this high sensory input, and that's when you may feel nauseous or dizzy, and then you're really conscious of that sense. We actually have two peripheral apparati, one per ear, and actually our brain is responsible for integrating those inputs. For those of you who have taken 3100 with Dr. Bent, this first couple of lecture slides may be a little bit of review, but for those of you who haven't, I just posted online, along with these lecture notes, an excerpt from the text Principles of Neuroscience that talks about some of these components of vestibular information. So I thought that might be helpful, just so that you've got a good reference for source for how the brain might integrate this vestibular information. So I will just do a brief overview. This is an image of the inner ear. What I really want to highlight here are the fact that we have the sacculus and the utricle. These are otolith receptors, and they're really important for determining our linear sense. So these get activated if we're on a moving sidewalk, moving just forward with no other information about where we are in space, or maybe up and down in an elevator. So the utricle and saccula are really important for those linear sensations of accelerations of the head. And then we've got the semicircular canals. So these are the superior, posterior, and horizontal canals, and they're really responsible for any, they work together to determine our rotations of our head. I also just wanted to point out the fact that these are all innervated by the cranial nerve, number 8, and obviously it has the cochlea, which is the hearing part, but we're going to really just focus on the vestibular section for now, although when we get to our case studies, you'll see that there is some overlap just because they're innervated by that same nerve. Children who have vestibular or have deafness also have some vestibular challenges as well. Okay, so just a close look at the semicircular canal, because they are a little bit, you have to sort of think about them in 3D space, which is going to be hard in this lecture, but I'll do my best. So we have that posterior canal, and in the first image at the very top of the page here, you'll see that we've got the eardrum there, you've got that sort of visual of the ear, the outer section of the ear, and this is obviously the inner ear that we're talking about. So the posterior is denoted by the P, horizontal, semicircular H, and the A is the anterior. And so this is like a blown up version on the right hand side at the bottom end of the bottom side of the page. And what you'll see is any rotation above that posterior canal, that's going to be emulating if you're tipping your head forward and backward as if you're nodding yes. The horizontal canal is going to indicate, if you're nodding your head, no. An anterior canal is going to be responsible for tipping your ear to either shoulder, left and right, to sort of stretch out those sternocleidomastoids if you're sitting at your desk all day. And what happens inside this avocado-looking object is actually the otolith organs themselves. So that's the utricle and the saccule. And you'll notice that disc, that gray disc, is like a gel-like substance. We've got these hair-like fingers that are denoted by the red fingers there, and movement of those red finger-like substances within that gel actually will tell us what's happening about if we're moving forward and backward for the utricle or up and down from the saccule. So again, you can take a look at and review that information in the Kendall and Schwartz Jessel textbook. Okay, the main thing I want you guys to think about with regards to the vestibular system is just the fact that we've got both the bilateral system, so we've got the left and the right horizontal canals. And in the first image A, what you'll see is those avocado-like structures, that cupula and the ampule. And you can hopefully you can imagine from A to B that as we have this angular acceleration of the head, you've got this cupula being displaced. And it's actually that movement which is detected by the hair cells and then relayed back to that cranial nerve 8. This is not a neural anatomy course, but I just wanted to point out in section C what's really important is that we have something called the Franklin plane, which just indicates that in fact our semicircular canals within the head are actually tipped off axis about 30 degrees. So it's not aligned up perfectly to the ground in terms of that would be 0 degrees from the horizontal. It's actually tipped upward about 30 degrees there. And that's really important, and it makes sense from an evolutionary perspective because of course we're often looking up when we walk to sort of look ahead. We learned that last week in last week's lectures. And so it makes sense that from an evolutionary perspective we developed, as we started walking on 2 feet, that we've got the semicircular canal that's tipped within our head. That's actually oriented to work with our ocular system. So that's a really important thing, as you'll see in some of our case studies today. And again, the bottom image there, it just indicates that the orientation sort of in that a different view, a transverse plane now of that left anterior canal and the right posterior canals, and obviously left to right, just to sort of give you an indication of where everything is oriented within your skull. Okay, so in terms of the actual firing, I'm not going to go into too much detail here, but I do want you to know that what's really happening is the orientation of these hair cells within the ducts. That's really what's critical, and the ducts work in pairs. So for this particular example, I'm going to use a head turn to the left. So let's say you're scanning and you're looking to see if it's safe to cross a road. What would happen is the fluid in the duct would actually lag behind just due to inertia. And so at a constant velocity, that fluid's going to move smoothly and with the actual head system altogether. So with that leftward turning motion, what you'll see is in the right semicircular canal, you can see the axis of the hair cells are going to be oriented just slightly to the left. And then in the left hair cells within the left semicircular canal, they'll be oriented just slightly to the right. And you can see that fluid motion in the ducts are going to be in opposition of the turning motion. And what that means is on the left-hand side, that cranial nerve 8, those afferent fibers within the hair cells of the semicircular canal are going to increase in firing, and the opposite happens on the right-hand side. So you're going to see a decrease in firing. So again, when we're turning to the left, you see a decrease in firing to the right semicircular canals, increase in firing to the left. And it's actually this information that the brain is going to integrate that will tell us what's left and what's right. And clearly this is something that we learn when we're quite young children. This is really important for vestibular ocular reflex because this is integrated with our visual system. So this might be something where if you've been to see a doctor, let's say if you've had a concussion, that kind of thing, they may be checking your vestibular ocular reflex to make sure everything is okay. They'll usually ask you to fixate on their finger or a pen or some object in front of you, and they'll ask you to follow with your eyes movement of that pen. And what they're looking at is that your eyes can move and you're not feeling too dizzy just with response to that. So your eyes are moving independent of your vestibular system. Sometimes they'll also do an action where they'll ask you to fixate on the pen, and they'll get you to shake your head as if you were saying no. Do this with a friend if you're living with someone right now, or with a family member, and you'll see that vestibular ocular reflex in play. So what should be happening is that if you're fixating your eyes on that pen, your eyes are going to be able to track that movement. So I wanted to demonstrate to you what it might look like at rest. So at resting rate, you may have 90 spikes per second, and this is going to be consistent from the left as well as from the right horizontal afferents that are coming from that vestibular system going into the cranial nerve and then being interpreted by the brain. When we make that left-hand turn, then what we see is an excitation, so perhaps it goes up to 180 spikes per second on the left-hand side, and then on the right-hand side, you'll see that inhibition on that right vestibular system, and so it may go down to like 10 spikes per second. This is actually sourced from the link that's below, the NOBA project, and there's some other really interesting information on that website, so check it out. So let's talk about Meniere's disease as our first case study. It's important to note that the cause of Meniere's disease is not well understood in the clinical literature. So there's some probable causes that have been proposed. Some of these include improper fluid drainage. So this could be just due to a blockage of the eardrum, so chronic ear infections, that type of thing. It could also be a result of an anatomic abnormality, which is just congenital. There could be some abnormal immune responses that are occurring. This could be, for example, allergies. Viral infections have often been reported in individuals who experience Meniere's disease. There could be a genetic predisposition for some families. I have read some literature in that area, and it seems like if you do have Meniere's disease, there could be a history within your family. It could be following a head trauma. And often individuals who suffer from frequent migraines also suffer from Meniere's disease. So really what happens in terms of the diagnosis for Meniere's is a physician will, or an ear, nose, throat specialist will run a whole series of different tests, and an individual is diagnosed with Meniere's disease if there's no specific cause, so it's idiopathic, for why they would experience the following symptoms, which are reoccurring episodes of vertigo, hearing loss, ringing in the ear or tinnitus, and a feeling of fullness in the ear. So these are the types of things that people will report. What's really unfortunate about Meniere's disease is that it's incredibly destabilizing and it's unpredictable. So these individuals will just wake up in the morning and suddenly feel quite nauseous. They can't move. They literally have to crawl to the washroom because they cannot stand. It is a really salient, very overwhelming feeling of dizziness. So it's not just a slight wooziness that you might feel if you got up too quickly, or perhaps if you're suffering from a head cold. This is actually quite debilitating. So most individuals will have to take time off work. It'll take anywhere from 1 week to 14 days to actually feel better after. And that could be the reason why they feel better after is perhaps maybe an infection will clear up, or they'll just sort of get used to that feeling, and their brain kind of quietens down or deregulates, downregulates the amount of vestibular information coming into the brain. But to have Meniere's disease, you have these transient attacks frequently throughout, like several months to a year or many years. So as you can imagine, for individuals who have Meniere's disease, where perhaps the source of why they have these transient attacks is unknown, it is quite destabilizing, and their quality of life is severely impacted. So for those individuals, they may decide to pursue a pretty aggressive type of surgical intervention, which is a vestibular neuroanatomy. So what this means is that for those individuals, let's say they experience this unilaterally, so it's on one particular side of the vestibular system. What they've decided to do is to actually have that cranial nerve 8 that innervates their vestibular apparatus cut, so it'll just be cauterized by a physician. So pretty invasive surgery, as you can imagine. So this is a case study that was published in 2004 that was looking at 9 individuals with Meniere's just before, so about 1 day, 1 week before they had this very invasive surgery. And they were just tracking them over a period of time to see what was the outcome of their surgery. And they were specifically looking at goal-directed linear locomotion because obviously that's a really important aspect of everyday life, being able to walk forward and do things like grocery shopping, just quality of life, general social aspects of life. So they had 10 healthy control individuals, and then they had those 9 individuals with Meniere's disease. And they looked at them before they had the operation. So what was really important here is that they had no walking deviations, but they were actually slower. So they looked at them 1 day prior to or 1 week prior to their surgery, and they looked at them 7 days after, 30 days after, and 90 days after. Okay, and they also looked at, in terms of the terms that you'll see for the reporting of the results, you'll see the following terms. So session, speed, and vision. So session was that pre-surgery visit to the laboratory, and then they looked at 1 week, and then 1 and 3 months later. Speed, they had those individuals walking at a normal speed and then walking at a faster speed. And vision, they asked them to do the walks with their eyes open and with their eyes closed. So this is the data that they presented in this paper, and I've posted this paper as well so you can read it in full if you wish. I've just highlighted here the normal speed, and the eyes open condition is the open bars, and the eyes closed is the hash bars. And what you'll see just from the bottom of these graphs all the way up to the top is something they've called a walk ratio. So this is just trying to normalize so that they can compare across the 9 individuals, so kind of like normalizing step length. So they have meters divided by the number of steps that they did divided by seconds. So it's just trying to normalize that data so they can compare across our population. And then above that, we've got the step length. Above that is the frequency, which is just the steps per second. And then we have the velocity, which is the meters per second. And then you've got your controls on the x-axis. And then you've got that D-1. So that D just represents like when the surgery was. So that's 1 week prior to surgery. So this is them sort of, I guess, in their everyday life prior to the surgery, and then 7 days later, 30 days later, and then 90 days later. Okay, so what did they show here in terms of that normal speed? So before, what you'll notice is obviously the controls, there's no difference between eyes open and eyes closed for any of those 4 different metrics, so walk ratio, length, frequency, or velocity. For D-1, what you'll note is in that surgical is following just prior to surgery, what you'll see is that there actually was, by those stars, it indicates that there was a statistical difference between eyes open and eyes closed. And what you'll see for most of those metrics is that they actually decrease. So they're walking slower, they're taking shorter step lengths. The frequency was statistically different. Doesn't look like it is from that D-1, but it is, I guess, according to their statistical analysis. And then velocity was also decreased with the eyes closed. So it makes sense if you've got sort of a dysfunctioning vestibular system and you take away your visual input, now you're left with proprioception. And so it makes sense that you would just slow that down because it feels very odd to be walking underneath those conditions. What you'll see is 7 days following the surgery with their eyes open. Those individuals with the surgery are walking, sort of comparable to what they were in terms of speed for velocity, and then the frequency is actually increased a bit. But what's interesting is that when they're close their eyes, that's where you'll see large decreases in terms of that walk ratio, in terms of the stepping length, and in terms of the velocity. So they really are impacted by having their eyes closed. Again, makes sense. Now they've got reduced, they have no visual input, and they only have vestibular input from one side, so from their unaffected side, because their affected vestibular apparatus that was experiencing these Meniere's symptoms has been literally severed. So there's no input coming from that cranial nerve. And then what you'll see finally 30 days post, what's really interesting here is those eyes open, eyes closed conditions, they start to normalize. So it's really not that different within the patient population, other than the walk ratio is a little bit higher with the eyes open. And again, 90 days later, you sort of see them start to equilibrize a little bit more, where you start to see a little bit of that decrease in the walk ratio and in the step length itself, but your frequency and the velocity metrics are kind of equalized. So I've sort of tried to summarize that with 1 week post. They deviated towards the lesion side, and I'll show you an image of that in a second, with their eyes closed. They seem to recover primarily from their impaired locomotor pattern at normal speed anyway, 1 month post. And 3 months post, they're still uncompensated in the fast speed, especially in the eyes closed condition. And again, I'll show you that data in the next slide. I just wanted to summarize this from that from the paper. Again, if you look at session, locomotion speed, and visual condition, these are their statistical analyses here. And what you'll see in the P column, you're all familiar with this, I'm sure. For a 95th% confidence interval, we're looking for data for values that are less than 0.05, and pretty much everything is statistically different except for locomotion speed and visual condition. So these are what we term from statistics main effects. So session would mean that a p-value of less than 0.0001 with that asterisk there indicates that the session they're all different from each other. So pre 1 week, 1 and 3 months, those the clinical population, so this is just for the Meniere's disease group, they're all statistically different, and the same for locomotion speed and visual condition. So you see main effects pretty much for everything, so they're really impacted by these surgical conditions. I want to highlight what I think is one of the most interesting findings from this work, and I tried to highlight that in the title here. So walking trajectory deviated towards the lesion in dark, and this was maintained even 3 months post-surgery. So this is there's a lot going on in these graphs, so I'll walk you through it. So the y-axis is the deviation of locomotion trajectory. We talked about this last week within our vision section. So this is a really good indication that if you can't walk in a straight line, that it's clinically there may be something going on there in terms of your control mechanisms are impacted. So on the bottom axis, so the x-axis, we've got D-1, so that's going to be before the operation in red, and in the purple is D+7, so that's 1 week following the surgery, 30 days, and then 90 days after the surgery. And I've highlighted at the top the normal speed condition, and then what you see at the top of the graph, this is the operated side, and then the intact side is at the very bottom. In the middle are the control participants. So these were age healthy matched individuals. So obviously they're going to have very little deviation when they're walking along a straight path, the control individuals. And what you'll see is that on the intact side, with the eyes open, so that's in the black lines, those individuals with Meniere's disease are actually able to walk no problem walking straight. They're pretty stable. If you look at eyes closed condition, so this is in the dotted line at that D-1 point, now you'll see that the individual with Meniere's disease actually have a deviation of about plus 1.5 degrees. So that just means that they're off center just a little bit. This wasn't statistically different prior to surgery, but it just indicates that when they close their eyes, they are having some deviations. They cannot walk a straight line. They're off by about 1.5 degrees, but again, not statistically different when their eyes are open versus eyes closed. At D+7, I really want you to pay attention to what's happening here. So it is statistically different, as is indicated by that asterisk. And what you'll see is when the eyes are open, so the dark line there, they're deviating towards the intact side by, plus or minus, so about -2 degrees, and there's a standard deviation there up to about -3 degrees. And that's statistically different from when they have their eyes closed. So now when their eyes are closed, what you'll see is they deviate on a positive trajectory towards the operated side. And now that's going to be about, just over 3 degrees, plus or minus 3 degrees. So you're up to about, 6 degrees with that standard deviation. 30 days after the operation, you'll see that with their eyes closed now, they're fairly close to that control group with very minimal, less than half a degree of orientation off of straight ahead. But with the eyes closed and the dotted line, that's where you're going to see big standard deviations again of about 2.5 degrees plus or minus up to 5 degrees. And then even 90 days after, you'll see that they're just slightly outside of that control band in terms of the deviation, but you're still less than 1 degree. And with the eyes closed, that's where you're, again, still seeing those fairly large deviations of about 3 degrees plus or minus out to 5 degrees standard deviation. So this is at the normal speed. You really see that obviously 7 days after, so just immediately following that surgery and the week following surgery, they're deviating. What's really curious is why they're deviating towards the intact side with their eyes closed, and why they're deviating towards the with their eyes open, and why they're deviating towards the operated side with their eyes closed. So that's kind of a curious finding. Let's look a little closely as to why we might see individuals moving towards their intact side with their eyes open 7 days post-surgery, and then moving towards the operated side with their eyes closed. So I just took that cartoon image that we discussed a few slides ago, and I've just placed it here so we can look at what's happening internally in terms of the neural firing. So let's say we've got the left-hand side is the intact side here, and the person's walking straight ahead. We have no input coming from the right horizontal semicircular canal, but we do from the left. And so now what we see is we've got this 90 spikes, let's say, on that left-hand side, and nothing coming from the right. So even with our eyes open, you can imagine we've got some input coming from the vestibular system on that left-hand side. So that's why we may deviate approximately 1.5 or so degrees to that intact side. It's a very small amount of deviation. That's really important to note. But now with the eyes closed, again, we're still going to have firing on that intact side, but no input from the right. But now we have no visual system either. And so if you imagine, we've got this sensation that we're moving to the left. The task was to move forward in the world. And so these individuals, 7 days post-surgery, they may interpret this increase in firing on the left as a drift to the left. So they're actually drifting to the left, so they're going to correct for that by moving to the right, towards the operated side. So even though there's no input in terms of the vestibular side, it looks like they're trying to correct for these types of deviations, and that's why they're moving more towards that operated side when they have no visual information to guide their behavior. Not only at a normal speed, but also at a fast speed. So I thought I'd also highlight some of their findings here. So very similarly to the graph that we just discussed above, underneath those fast speed conditions, you actually see with the eyes open, you see actually some deviations occurring, but not as many in the 7 days following the surgery. They're fairly close to the control, and the same about 30 days. There's some deviation from control, but with the eyes closed, that's where you see the largest responses, and again, moving towards that operated side, which we just discussed a second ago. I wanted to highlight what was happening here in terms of the control participants, and I do want to just highlight were there any if there was any questions from the class about if they had that surgery which obliterated the cranial nerve 8 on the right versus the left side, and was there any difference there in terms of laterality. So let's highlight that and look at those things. So the bottom graph, this is for a patient after a left, so it's a representative trial or trials, I should say, after a left vestibular surgery. And then above that is after right neuropathy or the surgery. And then the control subject is at the top of the page. On the y-axis is the lateral deviation, and on the x-axis is just that locomotion trajectory. Remember, the task was to walk straight ahead and to not deviate. So what did they see? First off, the control subject, left and right, it's a fairly, you can see a small oscillation there. It looks like a really low level sinusoidal wave. And that's really just them transferring their weight from left foot, right foot, left foot, right foot, but a fairly nice straight line is what we're seeing. And that's true for the entire population of the control participants. Very little differences between eyes open and eyes closed. And I now want to highlight what's happening 1 week post-surgery. So if you keep clicking on your slideshow, what you'll see is when vision was at initially for the left, you'll see that just slight deviation after the right surgery. You'll see that they're slightly deviated to the left-hand side. And when vision was absent, what you see is this imbalance. So now you're seeing them deviating to that right side where they had the surgery. And the same thing was actually true for individuals who had their left vestibular system obliterated. So that's when, they're walking slightly to the right, those individuals. And when vision was absent, what you'll see is they're moving now towards the operated side. And again, we talked about the mechanisms as to why. If you recall, one of the tasks that the patients had to do was they had to walk. That might be, but it's primarily due to the fact that it's the central processing of visual and vestibular cues, and that really messes up their accurate locomotor pointing. I also wanted to highlight some of the challenges that occur with elderly individuals. So this was a paper that came out a few years ago now. And it was looking at vertigo and dizziness in elderly. And one of the things that we do know from the literature is that with increasing age, there's a steady asymmetrical decrease in the ability to sense angular rotation about the head. So that's been reported in the clinical literature. And there's different methods. I won't get into too much of the detail, but you can use video head impulse testing where they actually look at how the eyes and the head move together, and you can also look at vestibular ocular reflexes in these individuals to try to quantify how much vertigo and dizziness can be attributed to these eye and vestibular system disruptions between the VOR. And oftentimes with elderly individuals, vertigo and dizziness is actually associated with a loss of dynamic visual acuity. So that means that their visual acuity if you go to the eye doctor, that Snellen visual test, the big E that you have to sort of look at, you'll see some losses in visual acuity. But more importantly, older individuals aren't able to compensate for fast head rotations with corrective eye movement. So if you make a quick motion of your head to the left, your eyes can still fixate and you'll see that they move to the right to sort of compensate for that. But with older adults, it seems like that integration between the visual and the vestibular system is impacted. And again, there's lots of different ways that researchers and clinicians have tried to quantify that. What is the etiology, or what's the underlying cause for this? There's been many different causes proposed in the literature. Again, you can look this up in that paper I've posted for you, but here's just a few in that first table within that paper. There could be some type of peripheral vestibular issues, so it could be bilateral vestibular loss, late onset Meniere's disease, a whole host there. It could be resulting of central nervous system problems like a vestibular migraine or following a stroke. It could be cardiovascular, so arrhythmias or postural hypertension. It could be due to medications or medication interactions. It could also be due to multimodal balance disorders, which just means that it's multiple systems that are impacted, and lots of other musculoskeletal and proprioceptive and somatosensory loss as well. So sort of a grocery list here of many different things that might be contributing to vertigo and dizziness within the elderly. But if you've ever worked with older adults or have older adults in your family, you'll find that many do discuss with you. They'll share with you that they do experience dizziness and vertigo occasionally. thought I'd discuss this paper with you, which is just using a gait analysis in patients who actually do express that they experience these vertigo symptoms, so dizziness and these very destabilizing events within their life. This is an older paper now, but one of the first ones that actually tried to use a gait analysis to try to quantify those vertigo symptoms. So we know that when lesions occur within the brain, that the gait controlling system involving peripheral and central vestibular systems are affected. And oftentimes this can result in abnormal locomotion and this feeling of dizziness. And the severity depends on the site and the size of a lesion within the brain itself. We also know that the cerebellum, in terms of that coordinated controlling area of the brain, of the central nervous system, I should say, and the vestibular nuclei both play an important role in different phases of the gait cycle during locomotion. So the purpose of this particular paper was to conduct a detailed gait analysis in patients with vestibular system disorders. And they were really setting about to do this to try to improve clinical understanding about pathophysiologies and abnormal or imbalanced locomotion. So they had a group of individuals. So they had individuals that were experiencing more peripheral vestibular issues, and then a group that was experiencing more central, so more within the central nervous system itself. They also had individuals that were healthy control matches, so they had 14 individuals. So within the peripheral group, they had 21 participants, and they had a series of different pathologies that were underneath this. So acoustic neuroma, so that's a type of a lesion within the brain, Meniere's disease, a whole host there you'll see. And then within the central group, they had individuals with spinal cerebellar degeneration, cerebellar tumors, those types of those types of issues, and they had 10 individuals within that group. Their trajectory. These researchers attached 2 foot switches on the heel and on the toe of their participants, and they also collected EMG. So this was located on the tibialis anterior and gastrocnemius muscles, so the calf and the shin muscles. And they asked participants to walk in a straight line at a comfortable pace for about 7 meters, so that gave them about 15 steps per side. Within. So I'll just highlight some of the control data first. This is from table 2 from that paper. This is from the healthy control participants. So they calculated the AH1, which was a time metric, and it tells them information about how long it took to go from heel contact to toe strike. I've noted in my slides that green color with the filled in circle. HA2 is the time from heel to toe off, and that's going to be noted by the white circle with the green line. The stance, this is the duration of stance time, so it's a temporal metric again. How long did they spend in stance, and that's going to be the closed black circle. The duration of swing in the open white circle. And then the duration of double support I've indicated in the red triangle. The GC max is the location of the peak gastrocnemius contraction and stance. We know that that should be at push-off, and that's going to be noted with that white triangle, the red line. And then they also looked at what they called TA off and on, which is the timing of the peak anterior contraction from the swing initiation, and then also from when it went on and when it went off, so just that on-off contraction from the tibialis anterior muscles. Really important for that dorsiflexion to make sure that we're not going to trip over our toes. And they noted they were going to characterize in the next slide, you'll see that they were trying to use these metrics to assess gait steadiness. And they looked at the coefficient of variation, which is a statistical measure, to look at how variable they were from step to step, stride to stride. And this is expressed as a percentage. And I'm going to note in my slide that asterisk is going to indicate abnormal values for our patient population group, so those older adults that had some challenges with their gait. To the results now. So there was a few takeaway points. First, they cautioned researchers that were looking for a single parameter that could show gait abnormalities between the peripheral and the central group. And they suggested that it may not actually be possible or appropriate to specify whether or not a lesion is peripheral or central just based on one just a single GAIT output parameter. So the example of this that they gave was that very first metric, which was the coefficient of variation, of the amount of variation within the time for heel to toe strike. And so if you look at this, I noted this in the green line here, the time for heel to toe strike, while the peripheral group had a smaller amount of variation of just over 40%. And the central group had close to 50%. You can note the standard deviation is quite high within that central group. So they caution against using that just because it depended on a given individual, maybe closer to the group that's presenting with peripheral lesions. So they really just cautioned clinicians and researchers from using just a single parameter just because of the variability within the data, the walking data. They did actually determine that some parameters may be indicative of central lesions, and these included the stance and swing and double support time. So I've highlighted double support in the red triangles here. Those seem to be really indicative and a better metric for trying to understand what was happening within the group with central vestibular lesions. So a more robust metric, if you will. They also found that there were some parameters that weren't specific, and they had a fairly low abnormal occurrence ratios, and this was on some of those EMG metrics. So I've highlighted a few in my slides here with regards to the peak gastrocnemius and the tibialis anterior values as well. And the last thing, I guess, the duration of stance time. One of the things that did seem to come out here was that the stance time was quite a bit higher in the group, the variability was quite a bit higher for stance and swing time within the central group. So perhaps not one particular or single parameter to show gait abnormalities, but if you look at a group of these parameters, so some spatial, some timing, it looks like together they may provide some indication as to whether or not an individual has a central lesion of the vestibular system or something that's more peripheral. So something to think about when we're doing clinical analyses in space. So we've seen a few case studies now with Meniere's disease and with just general aging, what happens within the vestibular system. I wanted to highlight what happens with children. So this was a paper published 2008 where they were looking at the onset of different motor milestones. We talked about this quite a bit in the developmental section of the course. But if you remember, for head control and walking, there's some specific timelines where we'd like to see those types of behaviors develop. And when kids aren't hitting those motor milestones, it's usually a flag for parents and clinicians to investigate a little bit further. And so if you remember, for children that are typically developing, so in this paper they termed it normal, they had a group of 22 individuals, and around this age, so somewhere before their 6th month, they are 6 months old, they will have acquired head control, so that's independent head control sitting down. For individuals, for children who actually have a hypoactive vestibular system, and this could be due to an autoimmune disorder or perhaps meningitis in the child. They have a group here of, so it's a group of different things that may cause a hypoactive vestibular system. So it is a diminished or a loss of function within the vestibular system. What you'll see is that that motor milestone gets delayed, and it's delayed by approximately a month, but there's quite a high standard deviation there. For individuals or children that are born without a vestibular system, it's more of a congenital issue, so it's completely absent in these individuals, and they had an N of 6 in this category. You'll see that independent head control is delayed to almost about 7 months of age, compared to about anywhere between 4 and 5 in a typically developing child, and that can be out almost as long as 8 months of age. So that's a fairly large delay. With regards to walking, as you know, most children, typically developing children, will start to walk anywhere between 12 to 13 months of age. But for children who have this hypoactive or diminished vestibular system, function, you'll see that gets delayed to about 18 months or so, or just past 18 months of age. They won't walk, and for some individuals that can be longer. It can actually be out to 2 years of age. And then for children who have a completely absent, so no vestibular function, for those individuals, that gets delayed to past 2 years of age, almost out to 3 for some individuals. So this just highlights the importance of a functioning vestibular system to acquiring some of those really key independent motor milestones, head control and walking. The same group of researchers published this paper in '99. They were looking at vestibular compensation in infants and children with both congenital, so you're born this way, versus acquired vestibular loss in both ears. So what they opened up this paper just by talking about the fact that children with semicircular canal anomalies and looking at vestibular compensation during development and growth was studied in those particular children. So for all of those children, the development of gross motor and balance functions was seriously delayed. And this was during the first 2 or 3 years of life. So that's essentially what we talked about in the previous slide. But by preschool age, they followed these children longitudinally, and by preschool age, all the children could achieve most of the landmarks of motor development. So these included things like head control, independent walking, and even running. But balance control functions at the age of when they started elementary school, so about 6 years of age, was variously impaired. So it was like almost on a case-by-case basis. And one of the reasons or the rationale as to why these researchers believe that this is happening, why these delays in motor skills are occurring, is due to a reduced or absent vestibular input. So remembering that any of those skills like head control, independent walking, and running requires the integration of input from the visual, somatosensory, proprioceptive senses. And at the same time, you've also got the maturation of the motor control systems within the cerebellum, the basal ganglia, and the motor cortex. So you've got this developing brain, along with, which is responsible for integrating these inputs. And now you have either an impaired or diminished with a hypoactive situation or completely absent vestibular system. So they just have challenges trying to integrate what maybe reduced vestibular input or no vestibular input as they're learning those really complex skills. Kind of an interesting. So for our final case study today, I wanted to highlight one particular case study that was discussed within that journal article. And this was a child that lost their labyrinth function due to meningitis at the age of 11 months. So it's a bit of a confusing graph, but I'll take you through it. So this was just a single child. Onset of meningitis was at about 11 and a half months for this child. Okay, so prior to that period of time, so that's when that meningitis occurred, prior to that period of time, the child actually had acquired some really important motor skills. So for example, head control. They developed head control a little bit earlier at about 3 months of age, and they had that head control all the way up to the time of the meningitis diagnosis. They were also crawling at about 6 months of age. They were sitting at about 6 months of age. They were standing at about 10 months of age, and they actually acquired walking early, so at about almost 10 and a half months. So they were a bit of a motor genius. Following the meningitis, however, they actually were set back quite extensively. So crawling never went away. That crawling behavior, that child could still crawl. But with regards to head control, it took them almost a month, so 2 to 3 weeks, to reacquire that independent head control. Sitting, they reacquired it around the same time as the head control, so at about 3 to 4 weeks post meningitis diagnosis. Standing, however, they did not reacquire standing until they were approximately 8 months following that incidence of meningitis. And they actually didn't start walking independently, although they were an early walker at 10 and a half months of age. They actually didn't reacquire walking until about 2 years of age. So this was just an interesting case I wanted to highlight, that this child was not, they were typically developing until that incident, And because of that diagnosis of meningitis, everything got basically set back. The clock got set back, and they had to reacquire all of those skills once again. So once again, interesting case study to discuss. When we're comparing our fine motor skills, we've talked a lot about gross motor skills. I wanted to highlight some of the fine motor skills that were discussed in this paper. And this is between infants with normal vestibular function and those with impaired vestibular function. So in this particular graph, it's hard to see. Each line is an individual child that was studied. And the white or the open circles are going to be healthy, typically developing children, and the black is the black dots indicate an individual child that has congenital loss of vestibular function. So also the white is connected by the dotted line. So what you'll see here is a series of 10 different more fine motor tasks. So pulling a hanging ring, passing an object one hand to the other, and you'll see that all the way down to number 10, which is building a tower with 3 cubes. And what you'll see here on the x-axis is when that skill was acquired. So for example, pulling a hanging ring, it was acquired by some children as young as 4 months of age, and that was our congenital loss. That was a child with congenital vestibular loss. But you'll see here, I guess the main take-home message here is just the variability that's occurring within the children. So you'll see for some children, everything is delayed. Those fine motor skills are also delayed past their counterparts, their peers that are typically developing. So just to highlight some of those fine motor skills as well. And finally, I wanted to highlight what happens in terms of compensation of vestibular loss in both children and adult patients, and those that have congenital vestibular loss and those that have acquired vestibular loss, for example, our previous case patient who had Meniere's disease. So I have no idea what jumbling is, so I'll leave that alone. But I wanted to highlight some of the other components. So for Romberg test, those with congenital vestibular loss and acquired, they're presenting with normal Romberg test. So this is where you stand with one foot in front of the other, so quite a narrow mediolateral base of support. When individuals are standing on one foot with eyes open, eyes closed, it's normal with eyes open for those with congenital loss, but quite poor for individuals with acquired vestibular loss. Eyes closed, it's poor and very poor for the acquired, so really challenging to stand on one foot with vestibular loss. Stepping tasks appear to be normal in those with congenital, so they're born with vestibular deficits, but it's ataxic or very uncoordinated stepping for those who have acquired vestibular loss. Riding a bicycle, individuals with congenital vestibular loss, no problems, they can do this, but it's quite poor for those who have acquired vestibular loss. Walking on a balance beam is possible for those with congenital vestibular loss, but impossible for those with acquired. Swimming is normal, but poor in individuals with acquired vestibular loss. And finally, diving into the water is possible for those who have a congenital vestibular loss, but impossible for those with acquired vestibular loss. In case this brings us to the conclusion of HK4070. So some last details. The final exam has now been rescheduled to April 29th at 17:30. Please go by the link that I sent you. There has been some confusion with regards to the final exams, but this should be the final schedule. And I apologize for the confusion on that. I posted some sample questions last week. Look for the link to the sample test in the coming days. That'll be posted on CourseLink. There have been some technical challenges and just some other things going on for me here in terms of winding up my research program, so I haven't had the amount of time I've wanted to dedicate to that. So thanks for being patient. It will be posted with lots of time for you guys to practice prior to having to log on to do that exam on April 29th. Please send me your questions regarding course content, not just this current lecture series on vestibular input to locomotor control, but also just on any questions, and I can try to post again next week, just taking up some of your questions on your exams. Good luck on all of your exams. I hope that they go as well as can be expected. And again, stay healthy and safe. I appreciate working with you guys this term. This is not the way I would have liked to have ended and said goodbye, but I wish you all the best on your future careers. I know great things will happen in your future, and I hope that we will soon be out of our social and physical distancing, that everybody stays safe and healthy in your life, and that you take care of each other. So please keep in touch. Let me know how things are going, and I'll probably have another announcement at some point before the final exam in this format, where we can take up any of those questions leading up to the final. All right, take care, and we'll talk soon. Study for us to look at.